MST op vrijdag is een lezingencyclus die bijna iedere vrijdag zal plaatsvinden. Een lezing om elkaar te inspireren en te motiveren. Hij wordt live uitgezonden van 12:30 tot 12:30 en is in de week daarna te streamen voor iedereen binnen het ziekenhuis. En we hopen daarmee elkaar natuurlijk te inspireren en elkaar te motiveren om de zorg elke dag beter te maken voor de patiënten die aan ons zijn toevertrouwd. Vandaag is de allereerste aflevering, buitengewoon spannend, met Michel van Putten. En het woord is aan hem, dit is MST op vrijdag. Hartelijk welkom allemaal. Ik vind het ontzettend leuk om de aftrap te mogen doen van MST op vrijdag. Een uniek initiatief van dit ziekenhuis. En ik ben best wel trots dat ik de aftrap mag geven. Vele mensen zijn verantwoordelijk geweest voor de organisatie. En we gaan vandaag spreken over epilepsie. Een aantal aspecten van epilepsie. En ik heb ook 2 studiogasten. Die zal ik zo aankondigen. Ik ga zo dadelijk over naar het Engels, omdat een van de gasten Engels spreekt en minder goed Nederlands. En er is ook de mogelijkheid om vragen te stellen. Dat kunt u doen via het YouTube-kanaal. En als er tijd is, zeer waarschijnlijk wel, dan zullen we daar uiteraard ook antwoord op geven. So now I'll switch to English. And once more, welcome everybody for the first episode of MST on Friday. And I'm really excited that this series of episodes started. And I'm also very happy that we have 2 guests in the studio. And one is my colleague, Dr. Kho, Kuan Kho, one of the neurosurgeons, Catarina Lourenco. So, Dr. Kho, Kuan.
Yes.
Very welcome. I'm happy that you're here.
I'm very happy to be here as well.
Yes. And to discuss the fascinating disease epilepsy and all its challenges. And also welcome to Catarina Lourenco. Yes.
Nice to be here.
Yes, well, I'm happy to have you here. And you're one of the PhD students in the group at the University of Twente doing a lot of research related to epilepsy that we will discuss during this session as well.
Cool.
So we decided to have it relatively informal and exchange our experience with epilepsy and also discuss our common clinical and research interests. And maybe it's a good idea, you asked me that, to explain a little bit about the disease in general.
Yeah, many patients who have epilepsy, they know of course, but when I am in town or people ask me, what do you do actually and what is epilepsy? Yeah. And I always tell them I'm just a neurosurgeon, and a neurologist or a clinical neurophysiologist like yourself probably would be the best person to tell what epilepsy is.
Yeah, well, I can tell a little bit about it, of course, and although I think many other people know a lot about it as well, but it dates very. I think the original publication about epilepsy is more than 2,000 years ago, but the essential part in epilepsy or in brains actually is that a typical brain contains both excitatory and inhibitory cells. So there's a constant battle between being active and being at rest. And it looks a little bit like the political discussion we are having right now, about the power and the contra-power, which should be in a good balance to realize good results. And that's very delicate, controlled in brains, but not at all times. And when the excitation becomes stronger than the inhibition, then people can experience abnormal brain function, and that's clinically noted as seizures. And the manifestations are extremely varied. So people can experience a loss of consciousness and rhythmic movements of the arms and legs. Other patients can experience a strange smell or strange feelings or déjà vu or jamais vu experience. So it's extremely...
So what is that? Déjà vu, jamais vu?
Yeah, so people
It
can
sounds
sometimes...
French.
Yes, it is French indeed.
It's French.
Well, actually, epilepsy research, France is extremely active in epilepsy research. And so people can also experience the sense that they have been somewhere already before, while there's no objective proof of that, or the sense that they've never been at a particular place where they are at, while, for instance, it is their home where they have been living for 6 years.
So they don't remember.
Yes, yes. So the manifestations are very large, and sometimes it even resembles psychiatric disorders. So there are even patients who are initially treated by a psychiatrist and eventually are referred to a neurologist to find out that the disorder is epilepsy rather than a primary psychiatric disorder.
Mm.
And so it's clinically also very challenging, oftentimes, to make the diagnosis.
Yeah, I can imagine,
Yeah.
because I see the same kind of patients, but you did the hard stuff, you did the diagnostics, and I see people with epilepsy, youngsters, children, but also people in old age.
Yes, it's basically it occurs at any age. There's a peak in the very young and a peak in the relatively older.
Mm-hmm.
That has to do with the causes of epilepsy. So a major group of causes is genetic epilepsies, where there's an abnormal control of the neurons. For instance, to come back to the excitation and inhibition, there is less inhibitory forces basically already in the genetic material and limiting the amount of inhibition in brains.
So these are the patients that are actually born with epilepsy.
Yes,
Yeah.
and you can do even genetic diagnostics to find out that there's abnormalities in, for instance, in the channel gating of neurons. And there's a very large group where it is the epilepsy occurs as a result of traumatic brain injury, for instance, or stroke, or tumors that tend to occur a little bit more after, say, 60, 65 years old. So that's also a large group of patients who suffers from what we call symptomatic epilepsy. Maybe it's nice to show one video of a patient with a particular type of epilepsy. It's a generalized epilepsy. With motor symptoms. And this is typically, I think, the picture that most people think of if you talk about epilepsy and seizures. It's, at the same time, it's good to know that this is not the most common type. It's maybe the most well-known type, but not the most common type. I think we can start the video. And so this is a patient in an epilepsy monitoring unit for diagnostics, and maybe he's also a candidate for surgery. We will talk about that later. And what is shown is an adult patient. He's reading the newspaper, and on his head there's a sort of a net. Below are many electrodes to measure the brain signals. We will talk about that as well. And you see the brain signals on the right. Brains continuously generate electrical activity, rhythmic activity, and that's shown on the right. And that also contains a lot of information relevant for epilepsy. And when I start the video, you will find a very sudden change in the behavior of the patient. This, maybe you can start the video. Yeah, thank you. Yep, this is normal, and now the video starts. So he's reading the newspaper, and very suddenly, you will shortly see it, there are no warning signs in this patient. He loses muscle tone. There's a lot of EMG artifacts now on the electroencephalogram. Pencil drops. Consciousness is lost already. This is a tonic phase. Then we have myoclonia. Yeah. So this is enough for now, I think, for the video. Maybe you can stop it. Yeah. Because this continues for another 2 or 3 minutes. And it looks quite impressive. If you've never seen it, a lot of people think that, yeah, the patient dies if this is the case. Fortunately, that is hardly ever the case during seizures. And after about a couple of minutes in this patient, we have the post-ictual phase that occurs in many patients, also shown on the video, where the patient is typically very tired, has a headache, actually many other symptoms as well. also memory disturbances. Sometimes patients are extremely agitated. Sometimes they are very tired. And that phase can last for minutes to hours. And some people even argue that the post-ictal phase is worse than the seizure, because the seizure is maybe dangerous if you're now working on a height, but it typically lasts only a few minutes, while the post-ictal phase can last for sometimes even a day or longer.
Well,
yeah,
it's an impressive video you showed, and well, we see that patient. It looks a bit disturbing. And,
yes.
But what interests me is the part of the video with those scribbles, those waves.
Yes.
Because I can see the patient, but I'm always imagining what's happening in the brain.
Yes. Yes. Well, I talked about the balance between excitation and inhibition, and the nice part is that all those neurons in our brain also generate electrical signals. And with the EEG that's also recorded in this patient, we can actually listen to how well the neurons talk with one another, and whether they are, in balance, the excitation and inhibition, or not. And that's maybe good to go to the next part about the diagnostics, because what we've seen here, it's quite uncommon to see a patient while he is having the seizure. So most patients are referred to the neurologist with a particular complaint, and our task can be, does this complaint fit into a particular seizure? And if that is the case, and the likelihood of getting another seizure is sufficiently large, then we call it epilepsy by definition. But to come to that conclusion is not so trivial.
No, I realize I have many patients with epilepsy, but as a neurosurgeon, most of the diagnostic work has been done.
Yes.
And sometimes patients ask me, but we had these symptoms for so long and they didn't know. And I try to explain that it's hard to discern those symptoms and to get this conclusion.
Yes, yes. So,
and then,
yeah. No, indeed. So if the patient has a few seizures while you are seeing him or her, then it's quite easy in most cases.
That's not normal, I guess.
No, that's quite abnormal indeed. The seizure frequency in most patients is not like several times a day. It's like a couple of times per year if you wouldn't treat it. Although there are cases where patients have tons of seizures per day, up to 30 or 40 even.
But if that's not the case, then how can you actually know if a patient has epilepsy or not?
Yeah, so we start with the history, the history taking, so the story of the patient, and but indeed if we conclude that it is most likely a seizure that the patient suffered from, then the question is the recurrence risk increased? Because that's basically the definition of epilepsy. And for that we can very well use the EEG, because basically you can find out with the EEG if this balance is now and then disturbed. And a colleague of mine compared it with electrical sparks in your home. But it doesn't get on fire, but you do find sparks now and then, electrical sparks now and then, which is not normal. So if you find EEG patterns where now and then you see that this excitation inhibition balance is disturbed, then the likelihood of another seizure is very large. So indeed we use recordings of brain rhythms. We've been using it for over 100 years now.
Wow.
In the diagnostics. Yes.
That's a long time.
Yeah. The first recording through an intact skull, which makes it relatively easy, of course, to use it for ambulatory patients, was in 1924. So that's almost 100 years ago, by Hans Berger. He was a psychiatrist, by the way. And
I always say psychiatry, neurology, and neurosurgery are actually one. It's the brain.
Yes. Well, maybe Hans Berger also had that. Although at that time the neurology wasn't an independent specialization yet. And but I can show you. Already it was on this video, but I can show you one video or image of an EEG, how it looks like. I think that's the next slide. So this is this is a kind of pattern we typically look at in patients who may have epilepsy. So we do recordings for about 20 minutes as a routine EEG, and we basically try to find sparks, abnormal short duration discharges in the EEG. And all the wiggles that you find here, so they're like typically 18 or 19 channel recording, measure the potential differences between two little areas of the brain. And they tell us whether those neurons behave in a physiological way.
But I'm wondering now, how do you find the sparks?
Yeah, it's basically people have found by experience initially that particular sparks have a correlation with epilepsy, and it's essentially taught by other people, and we do it visually. So we look at the recordings.
That sounds like a lot of work.
Yes, it needs a lot of work. And for 20 minutes, it's doable. It takes like 10 minutes. At the same time, we make, I think, over 250,000 EEGs in the Netherlands. In the MST, about 1,000 per year. So it's still 1,000 times 10 to 50 minutes if you only would have short duration recordings. And of course, you need to write down the report. So it takes a lot of effort, and it takes quite a long time to learn it, because most people, they can even hardly imagine that you can find something interesting in signals like this. And so this is a normal EEG, and at least part of it. And what is shown here is an example of such a spark. And not on the left, that's normal, and eye blinks, so you have to know that as well. But where it says epi after the red line is an example of an epletiform discharge. So this is abnormal. It's not a seizure, but it's an interictal discharge, we call it. And indeed, it's visual analysis. And the likelihood of this occurrence is not 100% in a short duration.
Oh, so then you can go through the whole 20 minutes and not find anything, and the patient can still have epilepsy?
Yes, and actually that is... so a normal EEG hardly changes your prior estimate of having epilepsy or not.
Okay.
So what would you conclude then?
Yeah.
Then we basically conclude it's still possible to have epilepsy, and we typically advise another recording or a recording of longer duration.
Okay. And what about brain scans, MRIs, CTs?
Yes, of course. That's a good question. That's also part of the workup. It's not only the EEG.
But can you detect epilepsy on the scan?
Actually, only in an indirect way, because the CT scan or the MRI could show a hemorrhage or a stroke or a tumor, and if the clinical symptomatology of the seizure fits where it is supposed to start, say around the region of the brain where the tumor or the infarction is, then it is very likely that that is the cause.
Okay.
So in some cases you hardly need the EEG, because the story plus indeed imaging is sufficiently convincing. And in some cases you can have genetic materials, or there are families with a lot of members who have epilepsy, then it's very likely that it is a genetic cause. So indeed, I mean, it's not only the EEG we use. Yeah. But it is, I think, in almost all patients with epilepsy, at least one, typically more than one EEG.
But we also see patients with a confirmed epileptic EEG, but with absolutely a normal brain scan.
Yes, many actually.
Yeah.
And which is in a way reassuring for the patient. But apparently this imbalance in neurons is not always visible on a scan. I mean, there's a limitation in what we can see with an MRI, unfortunately. So if it's really subtle changes in the connection or in the synapses, then it becomes difficult, if not impossible, for MRI scans to detect. Yeah.
So you're saying that it's still better to look at squiggly lines than to do an MRI to a patient?
I think we need both. We need both. But indeed, in some cases, the squiggly lines, the EEG, is indeed more sensitive than your MRI. That's true.
Wow, that's impressive.
Yeah. And but there are definitely challenges with this, because the sensitivity of the EEG is quite limited for a short duration. And if you make longer recordings, which is very nice, but then we have the problem of the increasing visual burden, as we call it.
Yeah.
And so ideally we would like to monitor patients for 1 or 2 days, but then we have 48 hours EEG. And then the visual assessment takes about 6 to 8 hours.
So what you're essentially telling me, Michel, is we're talking about a technology that exists for 100 years.
Yes.
And the way you make your conclusions is because you were taught by your teacher and he was taught by his teacher, and you just look at these squiggly lines. Is that what you're telling me?
Yes, and they already told me it will turn you grey if you do that, and they were right. And it takes about 1 or 2 years to learn the skill, because the biological variation is enormous, and also the signature of epilepsy in EEG recordings is also enormous. The example I just showed is just one way of the spark, but there are many, many, many flavors and signatures of epilepsy that makes it hard. So you really have to review many. And indeed, in a way, it's very old-fashioned.
Yeah, in my field, I'm a neurosurgeon. The technology like imaging, CT, MRI, that has helped our field tremendously.
Yeah.
But if I'm hearing your story, this looks like it has been stationary.
Yeah, well, that's I fully agree. And when we started recording in 1924, we started with visual analysis, and the gold standard in the clinic is still visual analysis. But that is going to change.
But there are computers who can beat the best chess players in the world. So visual inspection still is the gold standard. And
yes, and up till maybe 5 or 10 years ago, it was also believed that there was no other way to do it, because our brains are so unique. We are excellent in visual processing. We have a large visual cortex, as you know, and it was believed that it was impossible to beat it by computers until maybe 10, 15 years ago, because now this really changed. We can do image analysis and face recognition with computers, and that's actually why we started to try to apply particular techniques recently to the analysis of the EEG to reduce the visual burden, and hopefully to make it faster and more efficient as well.
With today's computer power,
yes,
I would put my money on it.
Yes. Yes.
But maybe you can tell me more. Or
well, that's why I'm happy that Catarina is here, because she has been working on this topic for I think about 1.5 years or 2 years maybe already.
Yeah.
So maybe you can tell us a little bit about your approach in this matter.
Yeah, you are completely right. We use computers for everything now. We can be chess players with computers. We can do face recognition with computers. Why are we not using computers to do this really boring job, right?
Well, I don't do that job.
Me neither,
okay,
thankfully.
Okay.
No, and I wouldn't know how to do it. I didn't have the training. But indeed, that's what we're trying to do now. We use these techniques called deep learning techniques. They're programming methods that use these things called neural networks, not the ones that you know, not the ones in the brain, but programming neural networks, so code, lines of code. And with that, we make the neural networks learn basically similar to what we do as humans. So when you're a child, you want to distinguish a cat from a dog, you are not born with that knowledge. So you ask your parents a lot of times, what's this animal? And they will tell you. And eventually you'll be able to figure it out.
Vice versa. You don't ask and they still tell you.
Well, then you have really cool parents. But indeed, that's how we learn.
Yeah.
And that's the same thing we do with neural networks. If we want a network to be able to distinguish a cat from a dog, we just give it a lot of cats and a lot of dogs.
Yeah.
We tell it which is which. And if we train it properly, it'll be able to tell with a new image whether it's a cat or a dog. And it's the same thing for an EEG. In this case, if we want to detect interictal discharges, so the sparks, the squiggly lines, we just give it a lot of those, and also a lot of EEG samples, a lot of brain signals without anything abnormal on it. And then we train the network to tell us when it finds something that is not normal in the brain signal. So maybe, I think we have an image that we can share.
To you. So this
that's what we do, indeed. We give it a lot of brain signals, and for testing, when we give it a new brain signal, we can run it through a whole EEG, whether it's 20 minutes, 24 hours, 1 week, and it'll just tell us when it finds something abnormal. So instead of having Michel going through, 24 hours of an EEG recording, he can just scroll through the abnormalities and make the diagnosis or think about if it's a patient of epilepsy or not.
Well, this sounds more like 2021.
I know, right?
Yeah. But how reliable is this method? Or is it experimental, or are you using it in the hospital right now?
Well, actually, it's doing pretty well. For the 19-channel EEG that Michel previously showed, we have been able to train a network that has a false positive rate under 1 per minute. So it doesn't make that many mistakes, which is pretty good. And I also think we have an image of the type of results that we get.
Yes, because that's one of the,
That's one of the things, because if I just show you that, like black and white stuff, it's really tough, at least for me, I'm not an expert, it's really tough for me to understand what the network is looking at, what's actually the result.
So actually you are at the same level of that computer.
Oh no, I'm way below the level of that computer.
But the computer doesn't know. You do some programming.
Yeah, the computer learns, and it learns a lot faster than I could.
Okay, yeah.
So in part you can subsequently ask the computer or the net, you do sort of brain research into the computer then as a next step. So why is this artificial neural network telling me that this is abnormal, right?
Yeah, exactly. Yeah. And we can actually analyze our results instead of just saying, yes, there's an abnormality, or no, there isn't anything here. We can look at the results as to what is the network looking for in a sample. And we do that by basically covering parts of the signal so that we can find out what the network is paying attention to. It's basically, again, like if we were looking at an image, if you're looking at a horse and you take the head out, you might be able to know that it's a horse, maybe not. If you take out most of the body, probably you won't be able to know that it's a horse if you only have a head. I don't know, you need...
If the head would be next to me in my bed, I would know. I've seen it in a movie or something, but...
Yeah, indeed, that's what we don't want.
I would get a seizure.
That's induced epilepsy right there.
But you brought an image, right?
Oh yeah, I did.
Where this is illustrated.
Indeed.
And I think it's right here.
So see, if you look at that, it's way easier, at least for me, to see where the network is finding something that is not normal. So also for a clinician looking at it, he can be more sure that it's not just a fluke or some mishap that the network is telling him, yeah, this is abnormal. No, it's abnormal because you can see that the squiggly lines are different than the others. So and that's my level of understanding.
Spotlight that directs you.
Yeah.
A smart spotlight.
And I think you also told me that at the same time you sort of verify that the network is indeed looking at relevant things, as we know from basically 100-year statistics.
Yeah, exactly. Because if I look at that, or if an expert were to look at that, they would say that the same part of the sample is abnormal. So if an expert and the network can agree exactly on what's wrong, then the network is probably telling us something that makes sense.
Yes.
And that's the empirical reliability of it. If we can be sure that we're looking for the same thing, we are pretty sure that we're doing okay in the programming computer part. Because otherwise, indeed, it would be just weird to have a computer doing the same thing as someone who's been trained for it for years. If we're not sure that it's at least comparable, then it's not something that we should be using. But we can be sure of that. And I think even in the implementation in the clinic, which is still ongoing, Michel has been doing some really cool tests. He's told me with EEGs in the clinic, where he just runs this and sees the result, and also whether it's close or not to the diagnosis and the report that was already there to begin with. So maybe you can tell us a bit more about that.
Yeah. So because the system is, the current version it's really good, and so what we are doing now is to compare the artificial intelligence approach, so the neural net that Catarina developed, with the lab technician and the clinical neurophysiologist. So we do a lot of ambulatory recordings in our patients in this hospital, about 100, 130 per year, I think. And also this is done in many other hospitals in the Netherlands and epilepsy institutes. But here about 100, 130 per year. It takes the lab tech about 3 hours, 3 to 4 hours, to review the whole recording and to make annotations about paroxysmal abnormalities, so presumed intra-ictal discharges that are subsequently checked by one of the neurologists. And so about 3 to 4 hours. The system, the AI network, it takes about 2 minutes to do the 24-hour recording, where it labels every 2 seconds of the EEG with a probability that an epileptiform discharge is present. So it's 2 minutes. And we compared, that's work in progress, but I think we can, in about 2 or 3 months, we will have a paper ready. We compared we had now 10 or 12 EEG recordings, and in 11 of those 12, it was an excellent agreement between the computer and the human. So we can easily just believe the AI network. It was exactly the same, no change. There was one case here where it was not as good as the human, and we also understand why, because this was a particular EEG pattern that is not very common. It's like there's a third animal beyond the cats and the dogs that you've never seen before, and then you don't always know what that animal is. And that was exactly the case in this particular patient. So it illustrates that you really need to tell the net in a smart manner, or show him sufficient examples. So in one of the 13 patients it was not good yet, but in all the other it was. So it's extremely promising. And I think within the next 3 to 6 months we will have a prototype really running here to be used alongside the medical specialist. And so yeah, that's I think quite it's very promising, and indeed there might be a change now after 100 years.
Yeah, well, it sounds cool, Michel, but you are comparing the computer results with your results. So you're training the computer to be Michel van Putten.
Yeah. No.
So, but how is the comparison between the neurologists in the Netherlands or in the world? Is there a big variation? Because I can imagine that if a computer misses one type of epilepsy, then maybe another neurologist would also miss that.
Yes. Yeah. No, it's a very good point, very valid, and so you need external validation, and I can also make mistakes, and so that's actually a step we will also shortly start. At least nationally, but probably some international colleagues will also collaborate. So we're going to send out 20 to 40 EEGs to clinical experts and ask them to label the interictal discharges, so the abnormalities, and we will compare that with the computer algorithm. And ideally, the AI network is on par, as good as the average board-certified clinical neurophysiologist.
But are there studies among neurologists and clinical neurophysiologists to compare how you do?
Oh yeah, those studies exist.
What's the variation?
Yeah, it's sometimes a little bit disturbing, and it also depends on the country, and also on where the neurologists have been trained. So yeah, we use the kappa score. You know that, of course. So kappa 1.0 is perfect agreement, and kappa 0 is completely disagreement between various observers. And I think the kappa scores are around 0.6, 0.7. So that's fair. And but it's definitely not perfect. So the first step would be to show that the system is on par with the average human, human expert. Yeah. And actually, such a study has been done a couple of years ago for image analysis with skin lesions. It was published in Nature or Nature Biomedical Engineering. I think in Nature. Where they showed images from patients, skin lesions, to 8 dermatologists and asked them to classify it, benign or abnormal, and what kind of abnormality. And they compared it with an image analysis done by an artificial neural network. And they showed that it was on par with the average highly qualified dermatologist. And so, which is another very nice example, I think, of the use of AI in the clinic.
Well, I really would put my money on the computer, because I think it can do better than the current.
Well,
that's the future.
Yes, well, it gets never tired, so that's a big advantage. It's very consistent. Yeah. It's relatively cheaper. Of course, there are also some ethical issues. Who are you going to believe when you disagree with the computer? That's not the topic of the discussion today, but it's definitely something that is it's receiving more and more interest, which is very good. So it's who is in the end responsible? Say you make a decision that is different from the computer, and the patient is not doing well, and the patient could say, yeah, but why didn't you obey the computer? Because that has been trained with many more examples than you. So it's very relevant and interesting discussion, I think, but it's a little bit out of the scope of today. And but I'm definitely very happy with the progress, because I think it's at least to be used alongside the specialist will really help.
Yeah, just
And-
the time that you save not going through
Yes.
the whole signal is already, I would
Yes.
argue, pretty advantageous.
Yes, and it doesn't bring the field forward because actually you use human power, human time to review EEGs. It's just simply something that needs to be done.
Yes.
But in the end, after 5 years or 10 years doing that, the quality of the field is still the same. You didn't improve it or anything. But it's as long as you don't have an alternative, you need to do it to keep the knowledge into people's head.
Yeah.
Yeah.
And in that sense, I think our field, the clinical neurophysiology neurology, will on this matter make significant changes or experience significant changes that already have been the case in radiology, for instance.
Yes.
With huge advances in imaging quality.
Yeah.
And yeah. Okay. I'm going to look to the audience that is hopefully listening as well. So this part was mainly about diagnostics and the challenges in diagnostics, but we think it's also interesting to talk about advances and novel approaches for therapy in epilepsy. That is not so trivial, so in the next 15 minutes or so we will talk about therapy for epilepsy. So we already discussed it a couple of times, Kuan, that not all patients can be treated with medication, which is still the first line of treatment.
Yeah. Do you know when the first anti-epileptic drugs were introduced?
That's a good question. We didn't prepare this, by the way. I think it was 1924. No, it was later, 1940, something like that. And I forgot the name, bromide or something like that.
There might be something like that.
Yes, but many, many years ago.
But nowadays we have lots of medication.
Yes.
And still, not every patient will benefit from.
No, if you make a graph of the number of anti-epileptic drugs versus time, then you find a very large increase in the number. We have, 20, 25 different drugs right now, I think. And some have been, are not considered anymore as useful, and others more and more.
Mm-hmm.
If you plot it on the same time scale, which is like 60 or 70 years, the fraction of patients that benefits from the drugs in the sense that it reduces their seizure frequency, it's about a straight horizontal line. So despite all the advances in better medication, or new medications, I should say, the fraction of patients who are refractory to drugs is still about 30%. And I think the main reason for that is that it's insufficiently selective. If you go back to the excitation inhibition, so you have neurons that are too active, neurons that should stop the other neurons from being too active. The drugs basically modify the activity of all the neurons in the brain, but sometimes you only want this little, little part of the brain to be controlled, which is by the typical drug impossible. It's insufficiently selective. They work both on the cortex and in the thalamus, and sometimes you only want particular neurons in the cortex to be modified in their function by anti-epileptic drugs. So I think that's one of the key problems in drugs. They are insufficiently selective.
Well, in my field, neurosurgery,
Yes.
well, it started with exploring the brain, of course, also 120 years ago. And lots of progress had been made on treating epilepsy patients. We learned about how the brain works from epilepsy patients. There were numerous neurosurgeons who were also researchers at the same time, and they found out important things of the brain, and also important things to treat epilepsy by brain surgery. So that's one of the possibilities of treatment next to all the drugs, all the modern drugs. And the basic idea of epilepsy surgery, it's called epilepsy surgery, is that you get brain surgery, and of course people, the physicians, the surgeons, or the team nowadays, they want to identify a part of the brain, I have a little brain here, a part of the brain that always starts the epilepsy seizure.
Yes.
If that's one part,
If that is the case,
if
right?
that's
Yeah.
the case,
Yeah.
then you could think, well, why not take it out? So it cannot spread the seizure anymore.
Yeah. But is any part of the brain, can you take that out without, harmful side effects?
And that's a good question. Well, neurosurgeons are very wary of taking parts of the brain out. We want to leave normal function intact. And so you cannot take every part of the brain out. You also have to test for the important, essential brain areas for example, for language, for motor function. And suppose your epileptic zone is in such an important, essential area, well, then you should be very careful with surgery or just decide not to do it.
Because you have alternatives, right?
Yes. So you could then decide we're not going to take it out, but we're going to sever all the connections from that part to the rest. But we leave that thing intact. It's done.
Mm-hmm.
It can help by, in some cases, and sometimes it's just not possible.
Right.
So epilepsy surgery, surgery where we disconnect parts of the brain, surgery where parts of the brain are taken out to reduce epilepsy, is sometimes not possible.
But you have alternatives, right? For that or not?
Yeah. The alternatives we still have are neuromodulation. So we try to modulate, influence the brain by electrical stimuli. And that's what we also do here at the Medisch Spectrum Twente, here in Enschede. We can try to influence the brain with electrical pulses in order to change the threshold for having a seizure. Mm-hmm. And you can do that in many ways. Of course, you could try to place some electrodes on the skull itself. Mm-hmm. And whenever such an electrode with some software and hardware detects a possible seizure, you can say to that device, well, we have to fire some electrical pulses now to that part, and then you can stop a seizure or the beginning of a seizure. Mm-hmm. It's called direct.
Yes. But here we mainly do vagus nerve stimulation, right?
Yeah. So the method I was talking about is FDA approved in the US, but we don't do it here in Europe. What we have here is direct deep brain stimulation. So we implant electrodes in the brain on the spot in the thalamus. It's the center of the brain. It's connected to every other part of the brain, and you can influence lots of areas and the so-called epileptic network. So you put an electrode in the brain. Mm-hmm. But you can also put an electrode on the so-called vagal nerve. Mm-hmm. It's the 10th cranial nerve, and it's starting in the brainstem, so it's connected to the brain, of course.
Yes.
But it runs via your cervical region to the rest of your body. Mm-hmm. With vagal nerve stimulation, we put the electrode around that vagal nerve here.
You have a device there, right?
Yeah.
Or not? Oh, yeah. So that's the electrode.
It's the electrode. You can put it here.
Mm-hmm. Yeah.
And the electrode is connected with a pacemaker that's implanted in the chest. Yeah. And you can program that pacemaker. And
does it always work?
It works.
Yes?
It works.
And you do like 60 implants per year, right? Here, approximately.
Something like that. Yes. 60, 70 implants per year. Yes. In the Netherlands, we have concentrated this type of surgery, and we do a lot of these procedures. And the two large epilepsy hospitals in the Netherlands, Kempenhagen and Sein, they know and they refer those patients when they don't respond to medication, and when they don't get an epilepsy surgery procedure, or when they're not fit for that.
But you told me that it's very successful, but also not in all patients, right? There's also a failure rate or non-response rate of about 30%, I think, 30 to 40%.
Yeah, and there's no such thing as a panacea. It's not a miracle device.
Right.
So the surgery is of course less risky than brain surgery.
Yes.
So that makes it pretty attractive, and it may be a last resort for patients. The not so nice thing is that I myself cannot predict beforehand whether a patient will respond to this type of vagal stimulation.
Well, that's indeed what we discussed last year, right?
It's a bit frustrating for me because I'm implanting these, and there are patients that really get better, and some patients, they get off meds, they can get a driver's license, they get a job, and that's nice to hear. But there's about 30% of the patients, after 1 year, after 2 years, you try to program that device, and you must conclude.
So you would be, that's what you told, right? That you're really interested in trying to find means to better identify before implant patients who will benefit or not.
Yeah.
And that's why we started this study recently, because I think it's nice to end with that, to shortly address that. The PREDICT study, where we try to identify patients who are candidates for vagus nerve stimulation and will benefit the best, and also identify patients who are potentially candidates for vagus nerve stimulation, but they may not be helped by implantation of this device, because the costs are like 15,000 to 18,000 euros, I think, per patient, and there's a lot of anticipation, of course, that patients would really like the system to work. So, and you actually told me about this company in Denmark that allows ultra-long measurements of brain function, because the idea was, if we can measure brain function for a very long time, not 20 minutes, not one day or 2 days, but ultra-long, there might be interesting information in the signal that can help us in identifying better patients who will respond versus who patients will not respond.
Well, you read literature as well, and we are in 2021.
Yes. So that's very good, and actually we
I was very frustrated with this old technology. If you look at other fields in medicine and other fields of technology.
But Kuan, I really, because of time. So this is the device, right, that you implant.
Such a cool thing.
So this is a little electrode.
Yeah.
And can you very shortly address? So you implant it not in the brain, right?
No. This is not going into the brain. This is an electrode that measures EEG continuously.
Yes.
And we can implant it under the skin, subcutaneously.
Yes. And it can stay there for a year, essentially, right?
Well, that's what they say.
Yes.
We have to find out, but that's what it's made for. So it's under the skin.
Yes.
On the skull.
But maybe it's nice, because we implanted now 3 patients. I think we are the 4th center in the world who do this. There was one in Denmark, one in the UK, and I think one in Australia, and I think we are the 4th who are doing this. I'm not sure.
Okay.
And we have a short video, I think, of one of the patients who was implanted last year with this device. In the meantime, she already also received the vagus nerve stimulation, and she can very well explain how it benefits her. And I think you guys have a video, right? So that can be shown.
Je kan er wel mee leven, maar toch als je op de grond valt, hersenschudding, en dan pas krijg je er problemen mee. Je gaat toch 2 keer nadenken over bepaalde dingen. Als je je wat duizelig voelt, ga je zitten en dan wil je eigenlijk niet meer staan. Voor het geval dat je wel valt, tegen de tafel aankomt of tegen de muur. Als je dan alleen bent, dat is een heel eng gevoel. Ik sta gewoon, of ik wil opstaan en dan val ik gewoon altijd op de grond. Het is echt de meeste keren dat ik dan op de grond val. En dat is gewoon het ergste. Ik val en dan helemaal trillen, shaken, schuimbekken.
Dat lijkt me voor anderen geen fijn beeld.
Nee, andere mensen hebben er ook heel veel moeite mee als ze dat zien. Helemaal mensen die dicht bij je staan, die hebben er heel veel moeite mee. Er is bij mij geen enkele situatie waarbij ze het na kunnen trekken. Het gebeurt gewoon op een willekeurig moment. En dat is het lastige bij mij. Nu draag ik een kastje bij me die alle data, al mijn hersenactiviteit, een EEG, gewoon 24/7 bijhoudt. Dit zelf werkt niet tegen epilepsie, maar ze kunnen wel zien waar het vandaan komt. Twee maanden nadat die elektrode is geplaatst, krijg ik een NVS, een nervus vagus stimulator. Dat is een soort pacemaker voor de epilepsie.
Oké, en die kan er dan voor zorgen dat je het niet krijgt?
Ja, die zorgt er dan voor dat ik minder aanvallen krijg, minder erg. En dus er is ook een kans dat je er dan helemaal vanaf bent.
Wat zou dat dan betekenen voor jouw leven als je er helemaal vanaf bent?
Dat is heel fijn, maar het is niet gelijk een zekerheid. Ik heb al een keer gehad dat ik 1,5 jaar aanvalsvrij was en dat het opeens terugkwam. Dus ik denk dat ik in het begin nog wel heel zenuwachtig ben en toch niet weet wat er nog kan gebeuren. Maar als dat eenmaal weg is, dan ben ik wel heel blij. Dan hoef ik gewoon nergens meer bij na te denken.
Yes, so this is really unique material because this is I think the second patient in the Netherlands who was implanted last year. And we are also very happy that she was so friendly to explain to a large audience why this might benefit her. This is also the device and so this is the recording device, and there's a little sticker you place here to record the signals. And this was funded, by the way, by a Pioneers in Healthcare voucher that stimulates research between the Medisch Spectrum Twente and the University of Twente. It's essentially seed money. So at present we are trying to collect more money to buy devices and to further research. Eventually we want 40 patients to be included in the study. And but I think the total number in the world is about 40 at present, given the numbers of the other institutes. I really think this is a very big step forward in recording brain signals. Also to reliably assess seizures, because what's typically used now is the use of diaries that have been shown to be extremely unreliable. Patients can often not record their own seizures. But at the same time, it provides unique material of ultra-long EEG measurements, including sleep, for instance, that we think has the potential to contribute to identifying biomarkers to treat patients with vagus nerve stimulation in a better way. Because, as was already addressed shortly, of the 60 procedures we do in this hospital per year, about 20 patients show no benefit of this device. And in closing, I think it's nice to very shortly recap major changes in our field in the next couple of years. You already addressed it, so I think the deep learning for the diagnostics will definitely be beneficial.
Yeah, and also if we keep doing these types of studies where we have a really huge amount of data, we can use deep learning for a lot more, for sleep stage analysis, for so many things.
Yes.
So that's definitely something we can do in the future.
Yes. So
well, I'm waiting for algorithms that can make a closed loop, that can read out brain activity and say, well, there's a seizure and let's try to stop the seizure. And
yes.
I think this type of research will impact.
Yes. Okay. Well, thanks a lot for this nice discussion we had. And thank you all for listening. No, it's okay. Oh, there's a question. Oh, I'm sorry for that. I didn't see the question. I was already trying to close the session, but there's a question. Is a craniotomy the only option for a neurosurgeon to access the seizure location? Well, that's a question for Kuan, I guess. A short answer, Kuan, please, because of the
Well,
the time.
sometimes it is done by craniotomy if we know where we have to do, where we have to be. But sometimes you can also make little holes and to go exactly to the point of where the seizure begins. That's the modern method, and it's all in development. But the craniotomy is a huge surgery.
Yes.
It's a big surgery, so we try to avoid this if possible.
Yeah. Okay, thanks. Well, this closes the first episode of MST on Friday. And I really want to thank my colleague Kuan Kho and Catarina Lourenco for being here as well. And I hope you enjoyed the session. And I'm very much looking forward to future sessions as well. And if there are any comments, suggestions for future episodes, please let us know. And I think I hope we have given you a short overview of challenging advancement in the field of diagnostics and therapy of epilepsy. A very challenging neurological disorder, with also a lot of challenging challenges in the diagnostics and therapy. And I think with AI techniques, as explained here, we will definitely improve the diagnostics quality in the sense of efficacy and reliability, and also with new technology, we can make huge progress in ultra long EEG recordings, and at the same time use the AI to analyze those signals that eventually will hopefully contribute to a better treatment of patients with epilepsy. Once more, thank you very much, and this closes the MST on Friday session of today.